My name is John Mak. I'm one of the medical oncologists in Auckland City Hospital. I work with Ben Lawrence, Veronica, everyone, Liana. So we're a bit of a small team. But the other part of the week, I work for a cooperative trials group. It's a not-for-profit group based in Australia. And it's called GI Cancer Trials, where I do some research. And I also have an honorary research fellow role at the University of Auckland. And as a disclaimer, this is for educational purposes only. Obviously, everyone's cancer is very different. So, we'll just be talking about general principles and a bit of a roadmap as to what we'll cover today. Really, the aim is not to make everyone here an expert in neuroendocrine carcinomas, but perhaps what we can do is try to demystify some of the language that we use in clinic, and also cover the general principles and our thought processes when we look at patients in front of us. So we'll cover the basics, and we'll talk about a bit about the science. We'll talk about the investigations, the treatments, and end on what's new and what's around the corner. So I thought perhaps we'll start with what is a neuroendocrine carcinoma, because this is an area that, to be honest, even with clinicians, often people get the terminology wrong, and there's quite a bit of confusion. So we'll start with a definition. So, breaking that neuroendocrine carcinoma down, the neuroendocrine part refers to the cell of origin. So neuroendocrine cells are found all throughout the body, and they basically act as messengers between the nervous system and the endocrine system, which is the hormone-producing system. And really the function of neuroendocrine cells is to try and release some hormones that help control various body functions. The carcinoma part of the name refers to the cancer, and carcinoma by definition arises from epithelial cells, which are cells lining the organs or tissues within the body. And I've put this de-differentiation word there, which is a bit of a jargon. So I apologize for that. But essentially, what we do sometimes also see is that rather than arising from neuroendocrine cells, occasionally these neuroendocrine carcinomas can come from non-neuroendocrine cells, which acquire neuroendocrine features as they grow and mutate. Moving on to the part that perhaps confuses most people. There are very similar sounding terms that we use. There's neuroendocrine neoplasm, which is the umbrella term that covers all sorts of different neuroendocrine cancers. And then within the neuroendocrine neoplasm umbrella, there's the neuroendocrine tumor, which are typically well-differentiated tumors. And then there's neuroendocrine carcinoma, which are typically poorly differentiated. What we mean when we talk about differentiation, whether something's well-differentiated or poorly differentiated, really we're talking about what the cells look like under the microscope, knowing that all cancer cells originate from a normal cell at some point. A well-differentiated tumor looks more like normal cancer cells. Looks more like normal cells, whereas a poorly differentiated one looks abnormal. It looks disorganized. So that's one point of difference. And then within the neuroendocrine tumor group, this can be low grade or high grade. And there'll be a slide coming up next, which will talk about grading. And neuroendocrine carcinomas, on the other hand, are always high grade by definition. Another term that you may sometimes hear we use is the term carcinoid. This is being phased out, and this is a term that we used to use historically. And carcinoids really mean cancer-like. We now know that neuroendocrine tumors are cancers. They're just slower, more well-behaved versions of cancer. The neuroendocrine carcinoma, on the other hand, sometimes we use the terms small cells or large cells, which we'll cover in a later slide. So we talked about grading, and really grading is a measure of how quickly the cancer cells are growing. And we mentioned before that differentiation, on the other hand, talks about how organized and how normal the cells look. So there is a WHO classification system that we use. Without going too much into the weeds, we use two ways of classifying whether something's a neuroendocrine tumor or neuroendocrine carcinoma. And the first thing is the differentiation. Again, that's how the cells look under the microscope. And the other thing is what we call a proliferation index. That's the Ki-67 or mitoses that you see in that third column. And there are certain cutoffs that we use. And basically what these tests are measuring are how quickly the cells are dividing and how quickly they're growing. So by definition, a neuroendocrine carcinoma is always poorly differentiated. They will, by definition, have a high Ki-67 or mitotic count. And these are often much higher than the threshold we use. And it sets them apart from the neuroendocrine tumors. And the reason why I'm harping on about the differences between a neuroendocrine tumor and a neuroendocrine carcinoma is that even though they share very, very similar names, the biology is very different. Well-differentiated neuroendocrine tumors are usually more indolent, meaning that they are slower growing. They generally have better prognosis. And sometimes we can even monitor these neuroendocrine tumors for a period of time, knowing that they'll take many, many years before they start to grow. On the flip side, for poorly differentiated neuroendocrine cancers, carcinomas, these grow and spread quickly. Apologies for the typo there. They tend to be more aggressive, and often they require intensive treatment with chemotherapy. So one of the key questions to ask your clinical team if you're dealing with a neuroendocrine cancer is whether your diagnosis is a well-differentiated neuroendocrine tumor or a poorly differentiated neuroendocrine carcinoma, because it makes a lot of difference. And the next thing we think about is the tissue of origin. So in simple terms, where did the neuroendocrine carcinoma come from? And in medical speak, we say, where's the primary? And these can come from anywhere in the body because neuroendocrine cells are found all over the body. The common sites are typically lung. Each hospital, each cancer center divides the workload slightly differently. Here in Auckland, patients with lung neuroendocrine carcinomas, typically these small cell lung cancers, they're treated by our lung medical oncology colleagues. And we focus more on neuroendocrine carcinomas outside of the lung, but each hospital is very different. Aside from the lung, the neuroendocrine carcinomas can also come from the digestive tract or the pancreas. They can come from genitourinary or gynecological organs. So these are organs like your bladder, prostate, cervix, and others. And we also know that in about a third of patients, we don't actually find the primary. We know that the cancer is a neuroendocrine carcinoma, but we may not be able to find where it originated from. Which makes diagnosing neuroendocrine carcinomas a bit tricky because the symptoms really do depend on where the cancers are located. There are general symptoms, for example, tiredness, fatigue, or weakness. There's loss of appetite or unintended weight loss, or pain or bleeding in the affected area. For someone with a lung neuroendocrine carcinoma, they may get breathing-related symptoms, for example, coughing or shortness of breath. Whereas for someone with a digestive tract neuroendocrine carcinoma, they may have abdominal pain or bleeding. Now, the other thing that we sometimes think about is the tumor function. You may have come across the terminology a functioning tumor or a non-functioning tumor. Unfortunately, this is more relevant for the well-differentiated neuroendocrine tumors because the vast majority of neuroendocrine carcinomas are non-functioning because they've mutated, they've change to such a degree that they don't really resemble normal neuroendocrine cells anymore, they often don't secrete bioactive hormones that can cause these clinical syndromes that you can hear of. Moving on to some statistics and epidemiology, really, neuroendocrine carcinomas are, first of all, very rare. They're less common than well-differentiated NETs, which on their own are already pretty rare. So this is a rare group of a rare group. They tend to be sporadic. As far as we're aware, neuroendocrine carcinomas don't tend to be hereditary. And unfortunately, they're often found at an advanced stage. Because of how aggressive neuroendocrine carcinomas are, they tend to spread early. So most patients come to us at a point where the cancer had already spread. Now, I guess a few important caveats here. There are things that statistics can tell us, and there are things that statistics can't actually tell us. So, statistics tells us, extrapulmonary, so neuroendocrine carcinomas outside the lung, they're often diagnosed at an advanced stage, and it tells us that the prognosis is generally poor in the average population. What it can't tell us is predict an individual person's outcomes. And that's where the art in oncology comes in. Everyone's very different, and everyone's cancer is very different. So the outcomes really depend on the site, the stage, the pathology details, how someone responds to treatment, the overall health, and also the availability of treatment, which may sometimes come in the form of clinical trials, which we'll talk about at the end. Moving on to diagnosis, there are a few tools that we use to help us build the picture. And the first thing that we often start off with is the tissue. In oncology, it's important that we know what we're treating because each cancer is different. And particularly so for neuroendocrine carcinomas, because as we've covered earlier, a neuroendocrine tumor and a neuroendocrine carcinoma are completely different. So it's important that we get an accurate diagnosis. And then there's imaging, so scans. So there's what we call anatomical imaging, and this commonly is in the form of a CT scan of the chest, abdomen, or pelvis. And occasionally we use an MRI if we need to answer certain questions, and this will help us give us information about the size, the lymph nodes and organs within the body. And then there's what we call functional imaging. You may have heard of PET scans, and there are a few different types of PET scans nowadays that we have access to here in New Zealand. And one of them is called FDG PET, and the other one's called dotatate PET. I have a slide later that tells you the difference between the two. And these are sometimes helpful, and I'll cover why later. And then the last thing in our toolkit is what we call molecular testing. Some people call this genomic testing. And really the point of this is to check for mutations, so DNA changes within the cancer that may tell us additional treatment options. And we'll talk about this later as well. I guess one thing that I do want to point out, though, is occasionally people need repeated tests to get the answers because of the trickiness of diagnosing neuroendocrine carcinomas. They're rare. Sometimes some people need additional biopsies or additional scans or even an expert opinion from another pathologist to help us settle on the final diagnosis. Often in clinic, patients ask me about their pathology report, and it is a very overwhelming document if you actually go through it. And there are a few common themes or common words that come up. We've talked about the differentiation. So again, neuroendocrine carcinomas should be poorly differentiated by definition. And then occasionally the pathologists may comment on whether the neuroendocrine carcinoma is a small cell or a large cell. And this is based on the appearance of the cell itself. So a small cell, unsurprisingly, looks small. And other things that you may find in the report are proliferation. So this is the Ki-67 and the mitotic count level that we talked about. And these help us to grade the neuroendocrine carcinoma. And then there are things called neuroendocrine markers. So there are certain stains, certain tests that the pathologist can do to tell us whether it's a neuroendocrine cell. And then there are further tests they can do that gives us clues as to where the neuroendocrine carcinoma has come from. So lots of useful information. And it's not uncommon for second opinion, as I mentioned earlier. And it's very reasonable if you're a patient to ask your clinician whether your pathology report or your actual specimens have been reviewed at the National Neuroendocrine Tumor Multidisciplinary Meeting, the NET-MDM. And we run this meeting.
It's just me and John. It's on. Oh, no.
Oh. Sorry, I can't actually see the chat. Is someone? No. Hey, Joe. I wasn't sure if that was a question, but we'll carry on. Where was I? Can you still see my slides, or have I lost it?
All good.
Yep. Okay. All right. Let me just see if I can come back. Perfect. And then there's staging. So staging is our fancy way of saying how far the cancer has spread. And stage is very different from grade. So stage describes where the cancer is in the body. And so most neuroendocrine cancer staging uses this TNM system that we use for lots of other cancers. It has three components. The T mainly describes how large the cancer is, where it started, and whether it's grown into nearby structures. The N stands for nodes, and this is mainly about whether nearby lymph nodes have been involved by the cancer. And then M for metastasis, which is another way of saying, has the cancer spread to distant organs, commonly the liver, the bones, or the lungs. Another set of terminology that you may hear in clinic is whether something is localized. So generally, this is talking about a cancer that's confined to a single area that's appropriate to be treated with curative treatment. There's local regional, meaning that it's just spread to nearby tissues or lymph nodes, but not further away. And then there's metastatic, which means it's spread to distant organs elsewhere. We talked about imaging a little bit earlier, so I thought I'd circle back. And one of the common questions I get is, will a PET scan help me if I already had a CT scan done? Does it add much more information? And really, it comes down to what questions we're trying to answer. I would say for general purposes, a CT scan or sometimes maybe an MRI scan is enough, and it tells us accurate information about the tumor size, where it is. An MRI sometimes is useful for certain body parts, for example, the liver or the brain or the spine. So we may tag on an MRI to give us extra information. And then there's the functional imaging, so looking at the biology of the tumor. So one of these is called FDG PET. And FDG essentially highlights areas within the body that's using a lot of glucose. And neuroendocrine carcinomas, because they grow quickly, they divide quickly, they tend to be bright on an FDG scan. We call that FDG avid because they're very fast growing. The other PET scan that we sometimes use in neuroendocrine clinic is something called a dot-to-tape PET scan. Now, this is very different. This is mainly useful for the well-differentiated neuroendocrine tumors because it looks for what we call somatostatin receptors. These are receptors on the surface of the tumor cells, and they tend to be found more in well-differentiated neuroendocrine tumors, but we very, very rarely see them in poorly differentiated neuroendocrine carcinoma. So dot-to-tape PET, unfortunately, not very useful in neuroendocrine carcinomas. Coming down to treatment and the management, And really, the way I see treatment, the first step is to uh, decide what's the intent of treatment. Obviously, if something is curable, we always try to aim for cure. And what is tricky about neuroendocrine carcinomas is because of their aggressive behavior. Often by the time they come to clinic, and often by the time they are diagnosed, unfortunately, most patients, the cancer have already spread and they can't be removed through surgery anymore. In those scenarios, we call treatment with palliative intent. And what we mean by this is we're using treatment to slow down the growth of the cancer, to help improve quality of life and to relieve symptoms and to buy us time. The way I see it is putting the handbrakes on the cancer and try to buy us as much time as we can. So when it comes to who's involved in the treatment of neuroendocrine carcinomas, I've put medical oncologists at the top, not because I'm a medical oncologist and I'm biased, but practically, it's often medical oncologists are the main people driving it. Obviously, we do involve the surgeons and the radiation oncologists, and every case we sit down with the surgeons and radiation oncologists to explore all options. Do they think something is removable with surgery? Do they think radiation has a role to either destroy the tumor or to, at the very least, help to control it even better? And obviously, we involve the pathologist, the radiologist, and sometimes the nuclear medicine team to help guide our decision as well. Obviously, we've got specialist nurses like Avril, and really, it does take a village, dietitians, pharmacists, palliative care team. And I've especially highlighted the palliative care team because sometimes there is a bit of a stigma. Sometimes people associate palliative care with end of life, but really, that's not the case. Palliative care is about managing symptoms, even at an earlier stage when we're pursuing active treatment, and it's about managing the symptoms, side effects, the stresses, and support. So it's not only for people at the end of life. So focusing a little bit on curative intent treatment. So really, this is for localized disease, and unfortunately, it is uncommon that we see patients find themselves in this scenario. But it's very important that we try our best when it's feasible. And there are a few potential building blocks. So surgery is often considered. So if a surgical procedure can help remove all visible disease safely, then that's often the go-to. But sometimes the cancer might be tucked away in a tricky position where surgery may be high risk, or sometimes people have different preferences. Some people prefer to have radiotherapy rather than surgery. In such scenarios, we can consider doing a combination of chemotherapy with radiotherapy to try and destroy the cancer cells. And occasionally we also use chemotherapy, either before or after surgery to try to mop up any microscopic deposits of cancer cell that may be lurking around to improve the rate of cure. And a key part of that building block is also surveillance. So once people have had their treatment, whether it's surgery, chemoradiotherapy, patients do need regular follow-up and imaging because the risk of the cancer recurring is still significant given the behavior of the neuroendocrine carcinoma. So when it comes to treatment decisions, thankfully we don't work in isolation. So we put virtually all cases through the neuroendocrine meeting, and we'll weigh up all options. Can we remove? Can we treat all disease? What's the risk? What's the benefit? And what's the recovery time? Moving on to palliative intent treatment, really, at this stage, it's about slowing down the cancer, and because of the nature of neuroendocrine carcinoma, often it has spread to different organs, in which case we need a treatment that goes all over the body, wherever the cancer may be hiding, to try and control it there. And we commonly use a combination of chemotherapy, something called platinum. Common names for platinum medications are carboplatin or cisplatin, and we combine it with another chemotherapy called etoposide. And this is a very common recipe of chemotherapy that we use for neuroendocrine carcinomas, whether it's coming from the lungs or elsewhere. And the treatment principle is essentially the same. Now, there are some alternative combinations that we sometimes use depending on the individual patient, and this can sometimes be fluorouracil-based chemotherapy, irinotecan. I think the details are not as important, but I guess the point is we do have other combinations that we use from time to time. And when someone's on treatment, we monitor their symptoms, we monitor their energy levels. Obviously, we look at the blood counts, the kidney and the liver when they're on the chemotherapy. And we also look at side effects. One thing that people are often worried about, understandably, when they come to clinic is what kind of side effects they might get. And I guess the thing that I try to reassure patients is, look, these chemotherapy, they've been around for a long time. They're not new. We've used them for such a long time that we know, typically, for an individual, what doses or sometimes what medications we might need to try and control the side effects. And with the help of specialist nurses like Avril and Liana, if patients get side effects, they've got a port of call they can contact and they can ask for help. And so people don't need to feel like they struggle with side effects, because a lot of the common things like nausea, we've got so many anti-nausea medications in our arsenal nowadays that we can control these. The other thing we monitor for is what we call treatment response. So often we require a scan after usually 3 or 4 cycles of chemotherapy to check on the progress and make sure that everything's behaving. And we personalize the treatment according to the patient sitting in front of us. And as a general rule, we try to aim for somewhere between 4 to 6 cycles of chemotherapy before going on a break. And I guess the other thing I would point out for neuroendocrine carcinoma is that because these cancers grow so quickly, they're often paradoxically, quite sensitive to chemotherapy. So often we do see a good treatment response, good shrinkage from chemotherapy. The only downside is because of the aggressiveness of it, chemotherapy unfortunately still isn't curable. It isn't a curative option on its own, and it's good at buying time, but unfortunately, cure from chemotherapy is unlikely. Moving on to another common question I get in clinic, immunotherapy. It's obviously an area of immense interest, and patients often ask, "Hey, look, if you have the funds for it, would you recommend adding some immunotherapy into the mix with chemotherapy?" And the reason why we think of this is because in the lung neuroendocrine carcinomas, so in the subgroup called small cell lung cancers, there have been research studies looking at the combination of chemotherapy and immunotherapy, and there is a modest benefit, and by modest, we're talking about the range of around 2 extra months of survival on average, based on large clinical trials. And so on that basis, immunotherapy is approved by FDA in this small cell lung cancer cohort. Like with most things here in New Zealand, unfortunately, it's not pharmac funded. But the question then is, right, we know there's some evidence of benefit in the lung, small cell lung cancer group. What about non-pulmonary, so neuroendocrine carcinomas from outside the lung. If we look at some studies, there's a review of patients in America who have been treated by by their clinicians with immunotherapy and chemotherapy. There is a suggestion of possible benefit, but the problem of relying on these patient record studies is it's often difficult to tease out whether any difference that we see is because of the actual treatment itself or because the patients are inherently different. So someone who might be able to afford immunotherapy might have more lines of treatment or participate in clinical trials, for example, that someone without the ability to afford immunotherapy. So there's some intrinsic difference with problems with relying on what we call retrospective evidence. But there is ongoing research going. So there is a much larger randomized study looking at this exact question of combining chemotherapy and immunotherapy. And it's done by a cooperative trials group. It's called SWOG. And where we're eagerly awaiting the results to tell us, look, do the same benefits? Are they seen in non-lung neuroendocrine carcinomas? Moving on and talking about further treatment options, knowing that unfortunately for most people, after their first line of chemotherapy treatment, the cancers will at some point grow. The what we call second line treatment is, I guess, an area of need. We because of how rare neuroendocrine cancers are, there is no standardized second line treatment. We often try different combinations of chemotherapy for people who have had a good response to their first platinum etoposide chemotherapy and have a long treatment-free interval. If they're able to stay off the chemotherapy for a long time, then we sometimes try the same. Sometimes we use other chemotherapy like irinotecan or fluoropyrimidine, and we're to a certain degree guided by where the cancers come from. Obviously, there's also a role for radiation, even outside of the curative setting. And radiation and other local procedures are often helpful at helping to control pain, stopping bleeding. If something's blocking off, sometimes radiation can help to shrink that area for a period of time to unblock. And whether there are specific symptoms, from different sites of disease, we often do rely on our radiation colleagues. The other thing that's of growing interest now is targeted therapies. So that's part of the reason why, wherever possible, I do recommend having molecular or genomic testing that we briefly mentioned earlier. And sometimes if we find the relevant mutations, it may mean that certain treatments may be useful. The other thing that feeds into this is clinical trials. So knowing that with a lot of this new development in cancer treatment, many treatments are very expensive. So we do try to bring along clinical trials, participate in clinical trials wherever possible. And this may be a way for patients to get access to treatments that would otherwise be very cost prohibitive. And then there's still best supportive care. Even if we run out of options, there's always a role for pain control, managing the nutrition, managing mood, and even social, psychological things like financial planning, planning, end of life, and best supportive care. I can't emphasize how important it is to actually improve quality of life during treatment. One other thing that sometimes gets brought up is what we call PRRT. This stands for peptide receptor radionuclide therapy. And again, it's more suitable for patients with well-differentiated neuroendocrine tumors. The reason is that the treatment works for by targeting cancers with this somatostatin receptor, and this is why we use this dotted tape PET scan to tell us how much of the receptor a cancer is expressing, and this is more relevant for well-differentiated neuroendocrine tumors, whereas for neuroendocrine carcinomas, they often have very low, if any, level of receptor expression, and often they grow far too quickly for PRRT to take effect. Onto sort of what's around the corner, something that we're excited about, something that we're keeping a close eye on is what we call a DLL3 targeting treatment. DLL3 is a protein that's found on many neuroendocrine cancer cells, and it's an area of lots of research. What the treatment does is using specific medications that connect the immune cells to cancers with this DLL3 protein. So in a way, it's like a type of immunotherapy, except you target the treatment by bringing the immune system to where the cancer is. Where we're at the moment, there are two main drugs in the market at the moment. There's tarlatamab, which is approved in America for, again, extensive stage small cell lung cancer, so advanced small cell lung cancer. It's not approved for non-lung neuroendocrine carcinoma yet. There are trials that are looking at things like tarlatamab and obrixtamig, both very similar medications targeting this DLL3, and they're doing so in neuroendocrine cancers. And here in Auckland, we are trying to get trials up and running as well, using one of these DLL3 targeted therapies. So watch the space. Obviously, access to these medications, eligibility for trial can differ from country and trial sites. So please do ask your clinicians whether your site might be one that's sort of considering these trials, and as a general rule, because neuroendocrine cancers are so rare and treatment options are limited, it never hurts to ask whether they are suitable clinical trial options. And so I'll end with some helpful tips, questions that can make appointments a bit useful. You can always bring a list of a written list of questions, and I always like people bringing their support people and extra pair of ears with them in clinic. The questions really cover things like where did the cancer come from, what is the type, the grade and stage of the cancer. And if there's one thing to take away from the oncology appointments, it's always to be clear as much as possible what the treatment goal is, and what are the treatment options. Once we've decided on the treatment, then it's important to know what the side effects are and what are the important ones that you should report immediately. And this is different from chemotherapy to chemotherapy, from targeted therapy to immunotherapy. This is very different. So please do ask and reach out if need be. And again, at the risk of sounding like a broken record player, ask if clinical trials or molecular testing is appropriate. And also, who do you contact if you run into problems in between appointments? And in Auckland, we're fortunate enough to have everyone Liana. So take-home messages. Really, neuroendocrine carcinomas are not the same as well-differentiated neuroendocrine tumors, as similar as the names are. Early diagnosis and prompt treatment are very important. Unfortunately, most cases come to us already at the advanced stage, and they often need systemic treatment with chemotherapy and symptom control. And explore clinical trial options, and to end on a bit of a positive note. Research is going on in this area, and new treatment options are being tested, are being explored, and the DLL3 is something that we're very keeping a very close eye on. So that ends my talk. Please feel free to share any questions or experiences you may have had. And yeah, thank you for taking time out of your evening to join the talk.